it is my absolute pleasure to introduce our first speaker. So, Dr. Andrew O'Brien is an adult hematologist and co-director of the Lifespan Comprehensive Sickle Cell Center at Indiana University, whose mission is to revolutionize, that wasn't on the slide, by the way, the way we partner with those with sickle cell disease and ensure that all those living with blood disorders have equitable, agile healthcare. He completed a combined internal medicine and pediatric residency and adult hematology fellowship at Indiana University. In addition to co-directing the Lifespan Sickle Cell Center, he also serves as hematology service line leader for the Indiana University Health Medical Group and program leader for classical hematology for the Division of Hematology and Oncology at the Indiana University School of Medicine. And so it's great pleasure I get to step aside and welcome Dr. O'Brien.
Good morning. Thank you so much, Dr. Nero, and the organizers for having me here today. So I've deliberately kept this short to have time for discussion, and because if I spent an hour talking about policy this early in the morning, all of us, including me, would be asleep. But so I'm going to hit some what I think are really pressing potential opportunities and threats for sickle cell-related policies in the current landscape, and then again, happy to have discussion if there are policy topics that I didn't hit that you think are important, please bring those up. There's a lot to cover, a lot of potential areas to talk about, but I chose out the ones that I think are sort of most pressing at the moment. Here are my disclosures. They have no relevance to the topics under discussion this morning. So a couple of the things to hit on: the Big Beautiful Bill Act, implications on Medicaid, what medical frailty means, because that's, I think, going to become very important if these Medicaid changes go forward, telehealth threats, Medicaid health homes, and then some resources for advocacy, because our voices can be heard, and I think we have seen some situations recently where we've demonstrated that if we share what the impact of our work is, that we can change the course of policy. So the Big Beautiful Bill Act, which we've heard much about lately. So this was one of the priorities of the Trump administration and did get passed into law. This mainly impacts Medicaid expansion populations. So there is some nuance in what Medicaid means and what Medicare means too, but I'll cover in a minute what exactly the Medicaid expansion population is. There are work requirements and then more frequent eligibility assessments as well. So all adding potential barriers to our patients accessing care when we're already, I think, all in agreement that access is problematic. So Medicaid expansion was part of the Affordable Care Act that allowed states, right? So Medicaid is a state-run program, so that's really important to understand in terms of the policy implications. It is a program supported by the federal government, but administered by states and partially paid for by states. And so it's really important to understand that when we're talking about Medicaid, it isn't a single federal program. And both understanding the implications of federal changes as well as advocacy, it's really important to understand advocating at both federal and state level is really important. So 41 states expanded Medicaid, meaning that it wasn't sort of the typical traditional Medicaid population of people like on Social Security disability. It included all adults up to an income level of 138% of the federal poverty level. But not all states chose to expand Medicaid with the passage of the Affordable Care Act. So again, an emphasis that just because this was an option with the Affordable Care Act did not mean states had to proceed with it. So most states, though, did eventually choose to do so. But you can see in the Southeast, there's this big gap. So how is the Big Beautiful Bill Act changing Medicaid eligibility? So there are a number of important changes. I highlight a couple, but there is a very extensive list of potential changes. You will note that many of these don't take effect for quite some time. So that both gives us time to plan as well as opportunity to potentially change the law. So again, it's really important that we continue to advocate, that we not just sort of accept this as inevitable, because many of these things don't go into effect for quite some time, and even if they do, right, laws can be changed. So we do have a voice, we can use that voice. So the first thing that's going to go into effect in about a year will be increased frequency of Medicaid eligibility checks. So really this is just more burden, more paperwork, more opportunity for patients to be kicked off Medicaid. So I think really important that we continue to support and help our patients navigate those changes, because they're going to have to continue to update their eligibility. And then a lot of discussion has gone into these work requirements. So these don't go into effect, again, for a little over a year. Again, this affects adults 19 to 64 who are under the expansion portion of Medicaid. So this does not affect people on sort of that traditionally qualify for Medicaid. It's the people in the expansion population. And the explicit requirement is 80 hours per month of work, study, or volunteer activities. But those who qualify as medically frail are exempt from this work requirement. And I think there's a lot of potential to leverage that for our patients, but there's a lot of nuance and a lot of sort of work on the advocacy aspect that's going to be required for us to sort of help that patients navigate that and ensure that that moves forward. And then there is also this potential looming cost share potential, which could be potentially very devastating for our patients. So the details are a little bit nebulous, and again, a lot of this will come down to how the states implement these requirements, but could be up to $35 per service for those in the 100 to 138% of the federal poverty level. So this could potentially even include like every time they come to get a lab visit, every office visit, every apheresis visit, right, every MRI visit. And if you look at the number of visits our patients have, this could easily become hundreds, if not thousands of dollars a year. So really important that we understand that that's looming. Again, we do have, 2 years? 3 years. What year is it? I don't know what year it is. 3 years. So 3 years to sort of potentially disrupt this. So opportunities to make changes, but there are these very looming risks that we need to be aware of and be working to mitigate. So what is medical frailty? Because this is really going to, I think, be important as we navigate Medicaid changes. So this is this sort of gray area between people that clearly meet sort of disability criteria and people who are sort of assumed to be healthy adults that can work and meet work requirements. So what the federal government has defined these things as are a disabling mental disorder, including serious mental health, mental illness, chronic substance use disorders, serious and complex medical conditions, which I think we would all agree sickle cell disease qualifies as, or a physical, intellectual, or developmental disabilities that significantly impair the ability to perform one or more activities of daily living. So I think the third and fourth points, I think both clearly apply to sickle cell disease, but it is not explicitly written into, no disease is explicitly written into the medical frailty definition, at least on the federal level. So really important that we understand that we have to be able to advocate and make it clear that our patients meet these criteria and that they truly do have a serious and complex medical condition, which is obvious to us, but not always obvious to others. You know, I think we've all experienced that, how often our patients look fine, and it can really be misleading if you just sit there and look at them, how debilitating their chronic disease is. So they really need us to be able to help advocate that they do, in fact, meet this criteria. So this is just part of a very large table of all the different ways. So again, each state makes all of these determinations on their own. So there's a lot of differences between who can first identify someone as potentially medically frail, as well as who can make that final determination. So if you look at Indiana, for instance, the health plan identifies someone as medically frail, but then it's actually the health plan that also makes that final determination. But in other states, it's not the same. Right, sometimes it's the clinician that does it, sometimes it's the state that does it, sometimes the person can self-identify. So really need to understand that this is a complex landscape, and you're going to have to understand how your state is implementing this and how you're going to have to help navigate based on the way your state implements Medicaid. And so this is going to be very different here in Indiana, for instance, compared to like New York or California that tend to be much more proactive and accommodating about these kinds of situations. So really important to understand that this is a state level decision, not a federal level decision about how medical frailty is applied. Okay, so that's sort of where I'm going to leave it about the Big Beautiful Bill. There's all sorts of things that we can talk about there, and happy to have a discussion about those particular items. But I think those are the most sort of pressing, potentially devastating complications. So then there's this issue of Medicare telehealth coverage. So many of us may have actually sort of forgotten, but a lot of the telehealth flexibility that we've been relying on since the beginning of the pandemic is actually not permanent law. So these are actually the only situations that there is permanent Medicare coverage for telehealth services. So people on dialysis at home, acute stroke, if you, wherever you are, you can use telehealth services for acute stroke. Mental or behavioral health disorders in your home, or there are situations where rural communities are allowed to go to a facility to get telehealth from someone else. But that is not sort of the telehealth that's become so pervasive, where we just all do virtual visits from our office and the patient is, I've had patients in Walmart, I've had patients on the bus, I've had patients in the hospital. So that sort of broad flexibility all has been coming from temporary waivers that were instituted during the pandemic. And there generally has been historically broad bipartisan support for these. The problem is Congress has just kept extending the temporary waivers and not actually permanently changing the eligibility. So the most recent set of temporary waivers expired on September 30th of 2025. And as most of us are probably aware, Congress has not done anything in quite a while. They have been taking vacation days because they have not been able to pass a budget. So they are still getting paid, but the rest of the federal government is not. So, right, again, this was the sort of broad flexibility that we all became pretty used to, that you could give any service in someone's home, didn't matter what you were doing, you were able to do virtual visits from their home. There were no geographic limitations about urban, suburban, rural. It didn't matter where you were. I've done virtual visits with patients down the street because they have children, they couldn't get out of their home. So there are lots of reasons, right, people can't schlep down to clinic, pay $20 for parking or whatever parking costs these days. So audio-only coverage was actually a relatively recent change that they gave that parity with audio and visual telehealth visits. So audio coverage, I think for most of this year, was covered the same as an audio video visit, as well as the same as an in-person visit. But all of these things were temporary waiver changes as a result of the pandemic, and those just languished and expired. So there was no explicit decision not to cover them. It was just nobody got around to it because they were too busy doing whatever else they're doing. But so far, this only affects Medicare coverage. The problem is typically what Medicare does, Medicaid does, and what Medicare and Medicaid do, private insurance typically does. So I have not heard about any Medicaid or private insurance changes so far. I think most likely everyone's just sort of waiting to see what happens once Congress starts to actually do something again. But I think if this doesn't get addressed, it will eventually cascade down, at least to most Medicaid programs. It's certainly possible. Some states may choose to continue, but most likely all insurance payers will eventually get on board with what Medicare does. The one situation where so this just affects reimbursement, so you can still do it, you just won't necessarily get paid for it. And so like our health system so far has said, we'll deal with it. Keep doing what you're doing. Keep doing what's best for the patient. We will deal with the financial complications as they come. I think they are doing that on the assumption that it'll eventually get addressed. But so it is really just a reimbursement issue. There's no reason you can't do it. You just won't get paid. The other piece that's still in place is there were previously restrictions that to prescribe controlled substances, which I would say pretty much all sickle cell providers do at some point, that you had to have in-person visits. That waiver is still in place. So that doesn't expire until December of this year. Although, again, that is a temporary waiver and will expire if Congress does not do something about it. But currently, telehealth is still sufficient to prescribe controlled substances. So this has broad implications, not just for us, but like our palliative care team extensively uses telehealth. That's most of, I think, what they do at this point. So broadly problematic beyond sickle cell disease. But that one we still have a little more time to get figured out. Okay. So I think there's opportunity and hope to get the telehealth stuff figured out. It's just a matter of Congress getting the other things dealt with first. There does seem to be broad bipartisan support for telehealth services. There just needs to be a space in which politically that can move forward. All right, so then I'm going to briefly touch on the cellular and gene therapy access model. So gene therapy was approved almost 2 years ago now for sickle cell disease. But it's still very hard to access, right? Incredibly expensive. And so mostly falling on Medicaid populations, and Medicaid, certainly in Indiana, but I think in most states, is in very dire financial straits. So navigating how to pay for extremely expensive interventions is really challenging within the current budget landscape. So CMMS has the cellular and gene therapy access model, which is designed to think creatively about how you pay for extremely expensive things. Very happy that they chose sickle cell disease as their initial focus to try to pilot these interactions and these processes to figure out how we navigate that and how we come up with sort of a sustainable model to get people access to very complex, very expensive interventions. So essentially what happens is CMS helps negotiate contracts between the states and the manufacturers. So again, this is mostly about Medicaid. And so Medicaid is a state-run program. So all of those agreements between the companies that do the gene therapy and the payer have to be on a state level. So CMS is there to navigate and help sort of create sustainable, fair contracts. But they are not directly negotiating, they're helping facilitate the negotiations between the states and the manufacturers to sort of really support outcome-based contracts so that, if gene therapy ends up not doing as well as we hope it will, we're not, as a system, paying for very expensive interventions that end up not really being beneficial to patients. So to try to improve access and to try to lower cost. So really, I think encouraging that this has not been threatened so far. Was started under the Biden administration, but still seems to be moving forward and supported at this point. So I think that's really encouraging. So just in case people aren't super familiar with the process that's involved and why we need sort of better structure around gene therapy. So for the people not as familiar with this, I'm just going to briefly sort of walk through the journey that's required to get to gene therapy, which is probably a conservatively at least 9 to 12 month journey. So really, you have to know about it, right? And have someone who can connect you with a center that's able to do that. I think probably most of us in the room would agree that that ought to be a center that is experienced in both cellular therapies as well as sickle cell disease and can provide a sort of comprehensive discussion about the risks and benefits of gene therapy, stem cell transplant, as well as conventional disease-modifying therapy, But you have to you have to be connected with someone who can start you on that path, be even aware that it's an option, and aware about where you can sort of access that care. So certainly in Indiana, we still have many adults at least that are unaffiliated and really getting no consistent comprehensive care of any kind, and so may not actually have a path to even know that this is available and know that there are places you can go to have these discussions. But you have to get to a treatment center, right? And then you have to be able to have that discussion with an interdisciplinary team about what's the right approach for you. If you decide that gene therapy is the way to go, you have to be taken off all of your sickle cell disease modifying therapy to enable you to get stem cell collection. And generally be put on red cell exchange to try to keep you healthy during that process, as well as, again, optimize stem cell collection. So that's probably several months of getting off therapy on red cell exchange and to the point where you're able to come collect cells. So again, cell collection has to be done at the treatment center. Is a very involved process, has some additional risks in sickle cell disease compared with malignant hematology indications, but can be a several-day process that you have to be here or wherever, right, at your treatment center to be able to ensure that you collect enough cells. Then the cells get sent off to the companies, which last I heard was like a 9-month turnaround time to reprogram the cells and then do all the quality assurance assessments to ensure that things were mutated in the appropriate way, that there aren't off-target mutations, et cetera. I think at least most of the sickle cell experts I've talked to, we all agree that probably just leaving people on red cell exchange during that process, you could potentially restart their medications, but right, that's going to take a while, and really important that you keep people as healthy as possible during that potentially 9-month period where you're waiting for the cells to be reprogrammed. Then you come back to the treatment center for probably at least a month of inpatient stay with high-dose chemotherapy, equivalent to like autologous stem cell transplants, and then get the transfected cells and then wait for engraftment. And then once things are sort of recovering, can leave the hospital, but still likely need very close routine follow-up at the treatment center to make sure engraftment proceeds and there aren't any sort of concerning chemotherapy side effects and all of that. And then figuring out what post-treatment follow-up looks like. So the requirement is that patients receiving gene therapy are followed for 15 years post-treatment. Right, that's a long period of time to track people to make sure that we're assessing outcomes, assessing off-target mutations, assessing complications, et cetera. So this is a very long process, right? And this $2 to $3 million cost that's quoted is just for the cell transfection. It is not for any of these other things. So the red cell exchange, the busulfan, the month-long hospital stay, who knows how many outpatient visits, all of the travel, the housing. So this is, for a single individual to go through this process, far more than that stated price. That is just for the companies who transfect the cells. So this really needs, the same way as stem cell transplant, a broad interdisciplinary team that are often doing a lot of things that are not typically reimbursed well. So really needs an innovative way to think about care delivery. So again, I think it's actually really encouraging and exciting that CMMS has put together this access model and is trialing this in sickle cell disease first. So I think there really are a lot of areas to be optimistic and excited about, despite the challenges that we're dealing with. Okay, so now there's this concept of health homes, which so for years, right, we have, as a sickle cell community, been trying to advocate for ways to provide all of the care coordination and all of these other services that our patients need that typically are not reimbursed well, don't work well in the sort of typical E&M billing model. So one of the ways that we have tried to approach this is by using the model of health homes, which are already built into the Affordable Care Act. They are already sort of established mechanisms to provide care coordination services, health promotion, transition follow-up, patient family support, CBO engagement, social services, all of these things that our patients, right, we all know need so much of. But again, these are federally supported programs that require states to adopt them. So they require what are called state plan amendments, where the state has to say, CMMS, yes, we want to do this. This is our implementation plan. This is what we want to use it for. And the federal government will pay for 90% of those services for the first 8 quarters, so 2 years of the program. If you look historically, most states that have done this have continued to do these health homes past the federal matching program because they have found that they actually improve care and reduce cost. But there is this 2-year period to sort of help states get through that transition process and get the program up and running. The barrier in sickle cell disease is that the way they were originally designed is it requires 2 or more chronic illnesses to sort of build a health home around, so like heart failure and COPD, for instance. And while certainly we can make the argument that people with sickle cell disease have that, it makes it a little more difficult to implement when it's not necessarily always the same 2 chronic illnesses, and so it's been more challenging to implement that for sickle cell disease specifically. So there has been an act. I sit on the ASH Committee Committee on Practice, and ASH has for several years now been advocating very hard for this as a model to improve sickle cell support. So we have been advocating for the Sickle Cell Comprehensive Care Act, which facilitates the development of Medicaid health homes specifically geared towards sickle cell disease. So it allows sickle cell disease to be a single qualifying condition. So the state can say, we want to make a health home for people with sickle cell disease. And that's all they need to say. You don't need to try to include risks of other illnesses, other chronic conditions. You just say, we're making one for sickle cell disease. And the act will require dental and eye coverage, because somewhere along the way, people decided the eyes and the teeth were somehow separate from the rest of the body and didn't need the same kind of coverage. But we all know are very important, both eye health and dental health, and the overall health of people with sickle cell disease. So we made sure that we included those. So essentially what would happen is if a state Medicaid plan does not include dental and eye coverage, if they built one of these health homes, they would actually have to cover those services as part of the plan. And again, allows sickle cell disease alone to be the qualifying condition for that. So we actually went to the Congressional Budget Office, I think like a year and a half ago, and after our discussions and providing them relevant data, they scored this act as actually saving money over time to the Medicaid budgets. Still have struggled to get it actually passed, but we have consistently been able to get bipartisan sponsorship of the bill, so I think there's still hope that this can move forward. But I think is a way of potentially structuring sickle cell care coordination in a more sustainable model than I think the way a lot of us try to navigate it at the moment. Okay, so those are, I think, the sort of highlights at the moment. I think there is a lot of opportunity for us to use our voice. So ASH has been working hard on trying to facilitate advocacy, so they have great resources. If you go to their website and Fight for Hematology, they have a lot of fantastic things we can use to sort of advocate for both research funding, clinical care funding, Medicaid support, et cetera. And I think the NIH specifically is an area where we have shown that we can get people to listen. So you probably all have heard that the Trump administration was asking for a 40% cut in the NIH budget for the upcoming year. But when you actually look at the budget acts, which have not been passed yet, but both the House and the Senate versions of the 2026 budget actually increased the NIH budget, despite the Trump administration's requests to decimate it. Similarly, the Trump administration request to restructure the NIH was also essentially ignored by Congress. So I think there's actually areas where we do all agree that like the NIH is important and is sort of a pillar of American society, but there are state-specific NIH fact sheets on the website to use in conversations with legislatures to show what the economic impact and the value of the NIH funding is to each individual state. There are tools kits for letters to the editor, which we can write as private citizens, which in discussions with the advocacy experts at ASH actually apparently have quite significant impact on legislatures and the people in your state and local areas. There are webinars on advocacy training and a lot of other opportunities. So I think this really is a very exciting time for sickle cell disease, having all of you in this room here, having support from ASH, having support from the National Alliance of Sickle Cell Centers. I think we really, as a community, are coming together to speak better with a single voice. I think we've struggled with that in the past of all speaking together loudly, but I think that's really changed. And I think this, despite the very significant threats that we face, I think there's actually a lot of opportunity for us to make meaningful change, and people do listen. So use your voice, you have it, and it is heard. So I think that's only about half my time. So very happy if there are policy topics that you think we should be discussing that I didn't mention or want to discuss more about these topics. I specifically left time for that conversation. I'll continue to stand up here. I know I'm a pleasure to look at, so.
I see. Okay,
Yes.
There we go. It takes a second to wake up like the rest of us. Before we start with questions, I really want to thank Dr. O'Brien for agreeing to do this talk. I felt for those of us who do sickle cell, it's particularly important for us to know the issues. We can't deliver care if we don't have a mechanism to do it. And sickle cell being at the bottom all the time will suffer the most. So we know a lot of other diseases, a lot of other patients we take care of are at risk. But sickle cell, I am worried, is going to be suffering more than some of the other places. I mean, there's a lot of other resources for funding and money to get things done, not with sickle cell. And I will say that it was a little bit hard to find someone who's willing and brave enough to talk about policy in an open setting. And so I don't know, any of you remember Mikey, back in the day, the commercial Mikey? I'm dating myself, right? Mikey. Okay, some people remember Mikey. So the cereal commercial, and none of the kids want to touch it, right? It looks a healthy cereal. Nobody wants it. And they come up like kids do with the plan, give it to Mikey. He'll eat it. And then he eats it and he's loving it. And they're like, he likes it, he likes it. So this is our Mikey for policy because no one wants to touch it. But it is critical we have these important conversations or we cannot make change for our patients. So with that, I want to thank you and publicly thank you for being the brave soul, Mikey. He gets the Mikey Award today. And with that, I'm sure there's some important questions and I can handle the front. Y'all are doing the back.
Thanks. I was curious if the Medical Home Act includes Medicaid coverage for individual sickle cell patients, or is that totally separate?
Yeah, you mean like an individual being eligible for Medicaid? Mm-hmm. Yeah, so that is technically separate. So right, it would only it's not so first thing to understand is right, these are state implemented programs. So essentially what the Sickle Cell Comprehensive Care Act does is it changes the application process for the health homes to make it easier for states to create sickle cell focused health homes. But what exactly that means is up to the state to decide. So one thing I forgot to mention, that even if the Sickle Cell Comprehensive Care Act passes, we then have another advocacy step of convincing our states that they need to submit plan amendments to implement them. And then what that implementation looks like is up to the state. And if the act passes, CMS will have to sort of create rules and guidance around it. Who knows what that would end up looking like. But the state has to implement it, and what the details are, the federal government will set sort of parameters, but what the details are, the state has to decide. So it's a great question because it is totally separate from like the medical frailty and Medicaid eligibility. So this is just to provide infrastructure for caring for people with sickle cell disease on Medicaid. But yes, they have to be on Medicaid already. Again, I think we have a sort of clear lane to sort of advocate for sickle cell patients needing Medicaid. But the health home is totally separate from eligibility determinations.
I know it hasn't passed yet, so maybe it's not known, but is there any age restriction for that? Do you have to be a lifespan clinic, or could it be just a pediatric home or just an adult home?
Yeah, so it would be however the state wants to implement it. So where they are, how they're structured, who's involved, all of that will most likely be left to the states. So like in Indiana, for instance, you could well say that IU has one, Innovative Hematology has one, and then they care for the state. Or there's one in Indianapolis, and there's one in Gary, and there's one in South Bend, and you all figure it out. And so how that's implemented really falls back to the state. So again, really important that even if the act passes on the federal level, we all then have to advocate again on our individual state levels to say, this is sort of how we want to implement it. There is already a model. So New York actually already implemented this just on their own. They sort of navigated this like the pre-existing eligibility to create sickle cell health homes. But again, it's going to be on a state level that the details of the implementation get decided. So yeah, you could have a pediatric one and an adult one. You could have one based on location, based on health system. That's all up to the state.
And does everyone know where to find the details of that, of the Sickle Cell Comprehensive Act and information on the ASH site? No.
Yeah, I think it's on the ASH site somewhere. But if you also just Google Sickle Cell Comprehensive Care Act, it takes you to the bill. I think in the current Congress, it's just in the Senate at the moment under Cory Booker. Last I checked, I think that's the current state of it. So you can see the details of the bill there, but then I believe there is stuff on the Fight for Hematology section of the ASH website as well.
Any other questions?
Hi, thank you, Farida from Nationwide Children's Hospital. I'm adolescent medicine, but I do get some crossover, obviously, with taking care of contraception for sickle cell patients. I'm just wondering, is it time to like really start playing up on the problem list of our patients? Because I obviously don't want to do anything illegal, but I would hate for some of these things not to be on the list. And I don't know, when does this go forward? So is it, if it's on the problem list now, it counts, or will scrambling to put it there later catch the eyes of people? That might be a simplistic way of phrasing it, but I'm just concerned about that.
Sorry, can you clarify putting what on the problem list?
So some of those conditions, like if they're not explicitly stated somewhere, should we, if they're mental health disorders, we take care of those a lot in adolescent medicine. Should we just remember to kind of keep documenting that, or?
So, I mean, I would strongly advocate for a variety of reasons that it's actually really, as much as all of us are frustrated with the EMR and have choice words about whatever particular EMR we use, right, the importance of having high quality data, I think, cannot be understated in so many ways. Both like on an operation, so I oversee all clinical operations for hematology, and as I try to like strategically plan, for instance, I look at the patients that our group is seeing, and the primary diagnosis code is sometimes like toe injury, heart failure. I'm like, I don't think that's why you were seeing the patient, but I can't tell, right? So data integrity is, I think, really important on a local level for your own sort of leadership to be able to plan and strategize. But yes, I think certainly like if people want to look at like Medicaid databases to figure out how many people have pulmonary hypertension, how many people have depression, how many people have abnormal menstrual bleeding, like, right? So I think that's a great point that some of the failings, I think, fall back on clinicians that we feel like it's not that important and whatever, I don't care about my documentation, I'm just trying to take care of the patients, and I don't have time to bother to worry about the problem list. Right, that's actually a very important data source. And so for us to be able to both do high quality research on large populations, but also to advocate correctly, we need to know what people are dealing with. And they only, particularly when you're talking about large populations, I mean, certainly things like registries help that are more sort of proactively monitored and maintained. But I think the value of having those data explicitly coded, I think is actually really important. So thank you for that.
I'm curious what your thoughts are about. I feel like gene therapy and gene editing is already very challenging to have patients have access to that. And now we have a bill that's going to slash Medicaid funding at the state level, and it's going to further worsen health disparities. And I'm just curious, like, how we as clinicians kind of navigate this world where we're trying to advocate for patients that are already disenfranchised and now further disenfranchised without access to potentially curative therapies, and what is happening from what you've seen at different centers as far as moving access to gene therapy and gene editing forward. Because I know at my institution there's a little bit of a break put on how much do we invest in moving all of this forward if we're not going to have funding to be able to actually offer it to patients.
Yeah, I think it's a great question. I don't think there's an easy answer. I mean, I think there's some reasons for optimism, right? I think particularly the medical frailty path, for ensuring people at least have continued access to Medicaid, right? And they continue to be eligible for Medicaid. But there are broader threats, right? To your point that even if they're eligible for Medicaid, if Medicaid doesn't have adequate funding anymore, then it doesn't really matter, right? So, I mean, even Indiana is discussing, in general, removing non-emergent transportation from Medicaid coverage as ways to try to address the budget deficits, for not just for our patients, but for everybody, right? And that's going to be particularly damaging for our patients who have so many appointments and so many barriers. So, I mean, I wish I had a good answer for you. I mean, I think, again, it's just about continuing to bring our patient stories to light and continuing to talk about more broadly what's required for comprehensive care and meaningful care, right? I think our patients are great exemplars of why traditional care delivery models don't work, and that you can't just rely on E&M physician billing, and like that doesn't provide the care that they need, and actually increase costs. And I think on a policy level, and this is why Ash worked so hard with the CBO on scoring the comprehensive Sickle Cell Comprehensive Care Act, is because I think we all know that organized comprehensive care improves outcomes and likely costs as well, but that's not always obvious to people who don't sit in our chairs day to day, don't sit in our patients' chairs day to day. And so I think there is opportunity for us to demonstrate that different care delivery models can control costs, right? And I think while it's potentially dangerous to draw attention to how much money our patients cost systems, I think particularly in states like Indiana, where Medicaid is so fractured that we have multiple Medicaid providers, they don't necessarily have as good an insight into how much our patients with sickle cell disease are costing them. Like, I think Maryland is a good example of when you have a single sort of unified Medicaid entity. Hopkins was able to work very well with them on, hey, you all are spending a ton of money. If you reallocate some of that money to us to organize care in a more meaningful way, then we can save you money in the long run, and have been able to demonstrate that in the long term. I think for us, like, do we work with Anthem? Do we work with CareSource? Who do we work with, right? So I think that makes it more challenging, but right, like our adult sickle cell comprehensive care program has cut hospital readmissions in half in 2 years. And so I think there is opportunity, I think often as clinicians shy away from talking about the money and talking about the finances, both because it, I think kind of feels icky to talk about it, and often because we don't feel comfortable and experts talking about it. But I think we as advocates need to become comfortable to talk about it, because if we structure that discussion in the right way, it's much easier to say, if you give us the structure for comprehensive care, we can save you money, rather than, right, this is the best thing for the patient, when you're talking about patients that, to be blunt, a lot of people don't necessarily care about. So I think my very lengthy and rambling answer to your question is, I think we have to become more comfortable talking about the financial realities that I actually think work in our favor, because we can show that comprehensive care saves money. I think everyone can hear you, JJ.
I wanted to ask, I mean, at least at our institution, we went from traditional Medicaid to managed care Medicaid. And what was very clear was that when they were negotiating that contracts, our institution, we were just such a little fish in the grand scheme. Like the house was on fire and we had like a little syringe with 5 cc's, right? So no one really cared about us. And to clarify with Hopkins, I think that it was Priority Partners. I think it was their own in-house Medicaid product that they negotiated with, and then one other because Maryland has fixed healthcare prices by a healthcare commission, but it had a pretty fractured market for Medicaid because it was a lot of managed care organizations that were doing it. And I think that's the challenge, right? It's a really fragmented healthcare third-party payer market for most areas, and we're not at the. It's hard to get to the table, even if you have the skills to negotiate and or have people helping you with that. It's hard to get on the agenda.
Yeah.
Okay, well, we'll give Dr. O'Brien another round for taking that on. Okay, so now it is time to break into your subcommittees. Again, the rooms are assigned and the kind of subcommittee titles. We welcome you. So most of you probably know which subcommittee that you are on, but if you are not on one, because we have a lot of new people, please join one that interests you and you want to hear more. Dr. O'Brien will be with me in the program development as well. So particularly if you have more questions there, please feel free to join us. Ignore the times at the bottom. So we will plan to break. So go to your subcommittees, get a little transition, coffee, whatever. Break about 10:20 from the subcommittee and allow time, because since checkout is 11, for people to get their bags and check out of their room, and then come back at 10:40. So we're shifting the time, giving a little bit longer break if you need to get your bags or things. And so break your subcommittee about 10:20 and then, come back at 10:40. All right, thank you all so much.